So now I call Dr. Suman Shree. The topic of Dr. Suman Shree is preoperative and intraoperative anxiety management. I am sure we all have some relatives who must have undergone any type of ophthalmic surgery, and we know the importance of the anxiety management for our near dear and for our patients also. So over to Dr. Suman Shree.
Namaste to all. I bring warm greetings from Netradhama Super Speciality Eye Hospital. I'm going to cover my talk in a brief outline being introduction, causes of anxiety, effects of anxiety, anxiety assessment, management, both non-pharmacological and pharmacological, DexMed, the magic potion, and the take-home message. What is anxiety? An unpleasant sensation associated with fear, tension, and nervousness, both in adults and children. Preoperative anxiety is secondary to a diagnosis of a disease, hospitalization, and a planned surgery. Obviously, intraop anxiety is only in regional anesthesia, local anesthesia, not for general anesthesia, as the anesthetist takes care of all of that. The prevalence is around 48%. Can you imagine that? What are some of the causes? Specific fears of surgery like operation, getting blind, claustrophobia, complications during operation, my vision not recovering completely, waiting time for surgery, operation failing, keeping still during the operation, especially under regional anesthesia, nudeness, perioperative pain, and the results or outcomes of surgery. What are some specific fears about anesthesia? Anesthesiologist error, after all we are humans, waking up during surgery, awareness, or not waking up at all, death, personality changes, loss of control, post-operative nausea, vomiting, a fatigue or drowsiness, and just perioperative pain. Now, specific to eye surgery, they are scared about some visual sensations during surgery like cataract. Of course, women and hypochondriacs. Bilateral eye surgery, significant predictor of pain is the anxiety levels resulting in stress. Also, fear of moving your head or eye during surgery, coughing, or just being uncooperative to your anesthetist or surgeon too. And finally, being injected by different practitioners for intravitreal injections. It is correlated to preoperative anxiety and hence should be avoided. So what are the effects of this anxiety? Activation of your autonomic nervous system called as a stress response. Rise in heart rate, BP, could lead to acute left ventricular failure, acute pulmonary edema, or increased myocardial workload and acute MI. You all know about the white coat hypertension. You also can have panic attack, breath holding, hypoxemia, and seizures too. And the dreaded cancellation on the day of surgery, increased anesthetic requirement, delayed awakening, post-op pain, a longer hospital stay, dissatisfaction, and a delayed wound healing. So how do we assess this? We have the Amsterdam Preoperative Anxiety and Information Scale for adults, which results in the global anxiety score, and accordingly, we can give either information or send them back to the surgical team or anesthesia team. This is how we do it in Netradhama. This scoring is incorporated in something known as the preoperative self-questionnaire. We also have an immediate pre-op self-declaration form for all symptoms on the morning of surgery, whether it is ophthalmic or general. For children, we have the MyPass, the Modified Yale Perioperative Anxiety Scale, or the Pediatric Anesthesia Behavior Scale, which correlates with the emergence delirium after GA. We also have the stakes score. Now let us see what we can do about this. Very important during pre-anesthetic evaluation is counseling, personalized empathetic communication, judicious PAC, and we also have the non-pharmacological and the pharmacological methods. This is how we have a pre- and post-operative instructions for eye surgery at Netradhama. What about starving? Rather, nil oral status of your patient. What are the pros and cons? Of course, if you do not starve them, what happens is the risk of aspiration, and especially deep sedation and GA, crisis requiring resuscitation, or certain logistical situations. But what are against starving? Because severe starving can cause dehydration, hypovolemia, omission of medication, enhance the pain and patient experience. So there's lack of consensus. As of now, no fasting for uncomplicated cataracts. And it can also cause anxiety, irritability, headache, resulting in hypotension and catabolism and insulin resistance. Now let us see the non-pharmacological methods. You have cognitive behavioral therapy, you have counseling, you have massages, aromatherapy, video counseling, music therapy, acupuncture, spiritual meditation, hypnosis therapy, and all we need is verbal counseling, like verbal anesthesia as we call it. Even in children, nowadays, virtual reality is being used apart from dolls and mobiles. There's a very important thing known as verbal reassurance, explaining to the patient, informing them about the protocols. We call it as Kalma Sutra, calm the patient down and clarify all the doubts. There's a new concept known as anticipatory reassurance. For every step in the cataract surgery, there is an anticipatory question and an answer. We can make our counselors learn these questions and respond in a standard operating protocol for every doubt a patient may have. It's an amazing tool that we can all use. What about the non-verbal comforting, like hand-holding by nurse, playing music in the OR, not only for the patient, even for the surgical and anesthesia team? Now let us go to pharmacological methods called procedural sedation. It alleviates anxiety. What is an ideal sedative? Reduces stress, raises the pain threshold, improves cooperation, striking a balance between reduction of pain and without losing consciousness and awareness. It's known as conscious sedation. And it should not disturb patient's ability to communicate. You're all familiar with the oral alprazolam that is being used preoperatively. Now we also have intranasal, dexmed and midazolam, and finally the intravenous techniques. Let us look what all we have. We have the alpha-2 adrenoceptor agonists. Dexmed is number 1, both intranasal, intravenous. The other is clonidine. We have various benzodiazepines, opioids like fentanyl, remifentanil, ketamine, propofol, and now the new kid on the block is melatonin and some gabapentinoids too. So you're all familiar with the oral tablet Restil or Angsit that we all give. It also helps the surgeon. In fact, there's a study which says that before phaco, it leads to lesser PCR, shorter OT time, and prevents repetitive surgery, lesser PCO. Essentially, even the ophthalmologist is happy with this. But of course, due to the adverse effects of delirium and benzodiazepines, its use has reduced. Let's see our magic drug, which I'm so excited about. We have done a lot of research and studies on Dexmed. It produces sedation, but arousable, and something known as the biomimetic sleep, ideal for daycare. And it does not have any psychomotor side effects. So it has a psychomotor sparing benefit. And that is why Dexmed is being promoted. It can be used intranasally, 0.5 mics per kg. In fact, we had a publication. Also, there is Dr. Chandrakumar has a single or intermittent bolus, which is also very useful in cataract surgery. And this is how we spray the nasal Dexmed. It's very easy to use. We also have some experience in giving it intravenous in retinal surgeries, and we have found out that 0.25 mics per kg over 10 minutes loading dose and maintenance of 0.25 mics per kg per hour titrated is very useful even in beta block patients, as long as there's continuous cardiac monitoring of these patients, which is very critical to the success of Dexmed. Nowadays, we've also started using intranasal Dexmed for pre-medication before pediatric surgeries. We give 1 to 2 micrograms per kg, and it is very, very useful. The onset is in 25 minutes, and the duration is about 85 minutes. Finally, the take-home message for all of you ophthalmologists is a thorough pre-anesthetic evaluation is mandatory, including your anxiety assessment score. Secondly, personalized communication with the 2 types of reassurance that I referred to, verbal and anticipatory reassurance. Customized pre-medication, both for GA and regional. Monitored anesthesia care, which we call as MAC, with titrated procedural sedation to reduce anxiety, facilitate a management of perioperative hypertension and tachycardia. And lastly, a perioperative anxiolysis, sedation, and analgesia definitely improves the surgical outcomes, both in adults and children, in general anesthesia, local and regional anesthesia. I take this opportunity to thank All India Ophthalmic Society and also the new All India Ophthalmic Anesthesiologist Society for inviting me and letting me share our knowledge with all of you. Thank you very much once again, Dr. Renu.
Thank you, Dr. Suman. I hope that patients will be less anxious and more happy and coming back with their relatives also to get operation.